white 15-page California Advanced Directive. They're on the back table there. We do have slides that are going to be the exact things that are on these forms. But if you'd like to have a copy for yourself, please feel free to grab one. So what I'm here to talk about today falls under the broad umbrella of life care planning. Planning for the care that you want in your life. We're going to talk about these two specific forms that are sisters with paperwork that Jeff does every day, and then cousins to the work that Audrey does with end-of-life planning and what do we want in our services. Our goals with this paperwork are to define specific treatments that you want for your health care at specific times, and to allow you to speak for yourself when you can't due to a health concern or other problem. There are two forms that we're looking at today. I'm going to first start by defining some of the terms I'm going to be using and talking about what each of these forms is used for, and then we'll get into the specifics of the forms. So first, I'm going to look at this pink form. It's called a POLST form, P-O-L-S-T. This is a physician order for life-sustaining treatment. This form tells us some very specific directions on what to do if someone is found not breathing and their heart is not beating, if they're found deceased. So those are our directives for healthcare and what they want us to do in that situation. An advanced directive is healthcare directions for your life as you age, develop health problems, and come towards the end of life. So it has a lot more room for you to be individualized and specific about things that you want in certain situations. This is your if this, then that, if this, then that form. Some of the things that we're going to define are things like CPR, that's cardiopulmonary resuscitation. That means chest compressions, manually making the heart beat if it's not beating for itself. We also use the word intubation, which means placing a breathing tube through the mouth, down into the lungs, and then attaching that to a ventilator, which will manually cause you to breathe. These are things that we can do in healthcare to keep someone alive. Those are things that happen at two different stages. So CPR we use when we find someone not breathing and their heart is not beating. The ventilator we use once we've successfully gotten you to the hospital. We have a word outside of the hospital, cardiac arrest, OHCA. And success rates with bystander CPR, people who've been trained and are just out in the street, they find you down, they start CPR, they start doing rescue breathing, they call 911. There's about a 10% success rate to getting someone from that situation to the hospital. If you had a cardiac arrest, your heart stopped beating, or respiratory arrest, your lungs stopped breathing in the hospital, at that point we have about a 40% success rate if someone who is trained in advanced life-saving training is there and present to respond immediately. And that is 40% success rate with the immediate resuscitation, bringing you back to life. It's about a 30% success rate for reaching hospital discharge, and about a 26% success rate for a 30-day survival, and a 21% success rate for 1 year survival. So these are things we are doing in various serious health situations. A lot of the times we think about, well, end of life, or what do I want from my life, without thinking about what happens to me if I survive resuscitation. We don't always get back to our independent baseline that we were at before. Sometimes people require ongoing ventilation. Sometimes they have severe brain damage or significant damage to their heart muscles. Sometimes cardiac arrest occurs because of other diseases like cancer or liver disease. And that disease remains terminal, even if we bring you back to life. So thinking about those things is very important. It's not just our singular decision of, do we bring you back? What happens to you afterwards? And how do you want us to manage that care? So that's part of the speaking for yourself when you may have a hard time after an event like this, or even setting it up so that you don't end up in that situation if you know you wouldn't want it. So we are going to start looking at our POLST form. Okay, so this is actually the back of the POLST form, which is our directions for the healthcare provider. And this has information about why we do this and what we're doing it for. So this is a voluntary form. This is a form that is signed and dated and can be revoked at any time. It can be changed at any time. If you decide you don't want it, you cross a line through it, write void, and make a new one. If you don't have a POLST form or don't have any advanced directive, you are full code, which means we do everything that is medically appropriate to keep you alive. A POLST form does not replace an advanced directive, they work together. A POLST form is typically something that we must have if someone is in a skilled nursing facility, but I think they're great for everyone to have because they are something that, this is very noticeable. If you were down at home, something happened when you were at home, we always tell people, put this on your fridge. EMTs will look on your fridge for a hot pink piece of paper. They'll know exactly what you want. So when we do this form, we review all of the information, we choose several treatment options, and then we write down who is the person who could make decisions for you. It also has a section for including information about your advanced directive, which is why they are sisters and they go together. Any incomplete section or unsigned section is automatically full code. So if this is not completed, you've maybe put X's in a couple of areas, but you never signed it, doesn't mean anything. Yeah. And then there are a lot of areas that can be gray in the medical decision-making that are not addressed on this form. This is primarily the, we found you down, what do I do now? A or B. So we're gonna start going through those sections. Okay. Sorry, I got ahead of myself here and didn't keep up with the slides. Okay, so our first section on the front of the page is section A, cardiopulmonary resuscitation, or CPR. If the patient has no pulse and is not breathing, what do we do? So are we going to attempt resuscitation, CPR, or are we going to not attempt resuscitation, do not resuscitate? Section A, the first one, means that we would start doing compressions. That means we press very firmly on your sternum to manually beat the heart. This typically results in fractured ribs if we're doing it well. People wake up and they don't feel great, and they often get pneumonia after that. So those are things to consider when we are in our 90s. If we have other health conditions, we're gonna have to do some recovery after resuscitation. With CPR, we automatically pair intubation. CPR, moving the blood in your body, does not help us if we're not getting oxygen into the blood. When you are outside of the hospital, people are trained to do rescue breathing. So they use their mouth to blow air into your body, or once you make it to an ambulance, they use oxygen with a bag mask and blow air into your lungs while doing compressions. And that moves oxygenated air, maintaining good blood flow to your brain and all of your body and organs. We also use something called an AED. That is an automated something defibrillator, sorry, can't remember it right now. And that we use to stop a life-threatening heart rhythm, and we use CPR to try and restart a life-sustaining heart rhythm. So we use the AED to stop your heart in a bad rhythm, and our hands to bring you into a good rhythm. All of those are designed to try and help your heart regain its normal function. So that is the first choice. We either do it or we don't do it. Typically, when I'm talking with people who are my patients, I say, if we choose the second option, We're saying, if I am found dead, I have died, I do not want you to bring me back to life. I want you to let me pass away peacefully as I have. So those two options, medical intervention or no medical intervention, are Section A. If we choose attempt resuscitation or CPR in Section B, we are automatically choosing full treatment. If we do CPR, we are going to do everything else. So everything else includes all medically effective means. Not every situation is one that can be recovered from. We may do CPR, we may intubate, and we may try medications to help support your heart and lungs and body, and find that we are not able to resuscitate. That's that percentage of people who do not make it to the hospital or do not make it to discharge in those earlier percentages I was listing. But these things include ventilation with tubing, IV medications, and things that help support your blood pressure. Lots of different medications that we can use to try and help resolve a medical problem that has happened for you. The second option in Section B is selective treatment. Selective treatment means we want to do some things, but not all of the things. This is typically what people choose when they say, I don't want to be resuscitated. If I'm found down, let me pass away peacefully. But until that happens, I still want to be treated for my medical issues. If I have a UTI, I want antibiotics. If I have a stroke, I want to go to the hospital and find out what's going on. If I break my leg, I want to be seen by a surgeon. So all of these things are covered in selective treatment. We're not going to do resuscitation or intubation, but we have a conversation about all of the other treatments, and the expectation is that you're still going to be receiving routine and emergency treatments up until you pass away. The third section is called comfort-focused treatment. This is what we use when someone is in the end of their life. This is typically what we start when someone moves into hospice care. This means that we expect someone to pass away within 6 months to 1 year, and their goal is to stay as comfortable as possible, avoid painful or invasive treatments, and they want to stay at home as much as possible. This is often something people choose when they have a chronic illness, for example, heart failure, where they might often go to the hospital because they're very short of breath or having chest pain. They're treated and returned home. They go to the hospital, treated, and returned home. And it's many disruptive visits. They may say, I don't want to go to the hospital anymore. I'm really sick of getting IVs and getting IV Lasix and having tubes put in me, and I just want to be able to stay at home, and I want to be able to call hospice and have them bring medications to my house to help me be more comfortable and less short of breath, and I don't want to go in anymore. And that's a very good time to talk about starting hospice and comfort-focused treatment. Sometimes people choose this when they find out they have a terminal illness. Sometimes people choose this when they've been having a chronic condition that is progressively worsening. And sometimes people choose this when they are actively dying. Sometimes people's family members make this choice for them, and they face a hard decision about what would my loved one have wanted. At what point would they say, this is too much suffering for me to endure? These life-saving health interventions are no longer providing me with comfort, and I want them to stop. So that's one of the huge benefits of doing this paperwork well before you have any major health issues, because that takes the burden of that decision from your family members and loved ones, and they can say, Mom said, when the doctor says we can't do anything else to help, she's ready to go on comfort-focused treatment. The doctor has said that. It's time. And they don't have to make an agonizing decision for you. You have made that decision, and they're respecting your choice. So those are our choices about resuscitation, and our choices about the general categories of medical treatment. Section C on our POLST form is about artificial nutrition. Artificial nutrition can be something that is hugely beneficial for people. If for some reason you can't swallow, we can use IV, we can use a tube through your nose or a tube surgically placed into your stomach to give you nutrition and keep you alive. These interventions come with some discomforts and they come with some risks. Sometimes it's worth it and sometimes it is not. And that is very highly situationally dependent. The things that we know about artificial nutrition, there is no artificial nutrition that you get through an IV tube that can match eating or food that is placed into your stomach. So IV nutrition, parenteral nutrition, is something that'll get us through a period of time. It is rarely something that can be used permanently, even with a permanent catheter, so that you don't have to have an IV in and out, in and out, in and out. There's a short-term tube that goes through the nose into your stomach, and we can keep that in for a few weeks. That is something that is largely uncomfortable. As a nurse, I have never had a single patient say, "I'd like to keep this tube in. I really enjoy having this tube in." I have had a scope done in my own nose, and I will have notes in my paperwork that says, "If you must put a tube in my nose, you must restrain me, because I will pull it out at the first opportunity." This is just something I know about myself. They're not comfy. They can be life-saving. When someone requires long-term nutrition, which is something we see commonly in people who have swallowing impairments, disabilities, that kind of thing, we use an implanted feeding tube. These are life-saving and wonderful interventions. When someone is in the end of life, they are not always beneficial. Some of that is because of the cause of the underlying medical issue. If your body is not able to absorb nutrition because it is really focused on fighting another illness or run down from a disease process, we can have issues with not moving the liquid food through your system, which means you could end up throwing up a lot. You could end up accidentally inhaling some of that food, which leads to pneumonia, which can be life-threatening in its own right. And because it is liquid food, it does often cause people to have chronic diarrhea, which leads to other discomforts and other indignities. For some people, this is worth it. They say, "I do not want to starve to death." I hear this from people's family members all the time. I don't want them to starve to death. That's a scary thought. It's a really scary thought. When someone is in an end stage of life, and I particularly work with patients who have dementia, we know that their brain has been damaged by the disease and does not communicate with their body well. By the time they are not eating anymore, they no longer want to eat or drink anything, their stomach is shutting down. So if we put the tube in, we introduce all of those discomforts, and the studies show that it does not help prolong their life. There are instances with other diseases where that is also true. The body stops prioritizing food intake when it is actively dying. So forcing food in those situations can often lead to other discomforts. Some people say, "I don't care, I want them to use it." Great, then we mark long-term artificial nutrition. You have the right to make that choice. You can also mark a trial period. That might be really useful in a stroke. You had a stroke, you're having some trouble swallowing, we don't know what's gonna happen in the next 6 weeks. Absolutely appropriate. Let's use some trial artificial nutrition and see how things go. And we'll continue to communicate about the decision-making that needs to take place. Some people, I myself, would say, no thank you. If I can't eat it, I'm good. I would like to eat and drink as long as I'm able to. And when that can't happen anymore, as long as it's not like a car accident when I'm 30, that may be the time. And these are kind of the relative things that are hard to individualize in these conversations. If someone has a car accident that's sudden, this paper doesn't necessarily answer all of those questions. And that's when we look at the advanced directive. This one says, black and white, what do you want? Now, if you have conversations with your decision maker and you talk about, well, if the doctors thought I was going to get better, if the doctors were saying this, I would want to try that, they'll know those things. And they'll be able to say, she marked this on the paperwork, but she always said. And then you can move forward with your care that way. Next on this form is section D, which is about information and signatures. You have the opportunity to mark down who the healthcare provider talked with, you, if you are able to make the decisions at this time, or a legally recognized decision maker if you have a legal document. We can write down that information. When was your paperwork signed? Who is marked on there to make decisions for you? Then it is signed by your healthcare provider that you've been talking with, and then signed either by you or your recognized decision maker. In California, if you're married, by law, then the person to make decisions for you is your spouse. If you have children and your spouse declines to make decisions or is unable themselves, then it goes to your children. This sometimes leads to trouble. If you have a number of children who disagree about what should happen in your health care, this can delay things. It can cause issues. It can cause you to get medical treatments you don't want, which is why we always say talk to who's making decisions, make sure that they know what you want. Then on the back of this form, I didn't take a picture, there's the opportunity to put a second person's name and information, so your backup decision maker. Then we move on to our California Advanced Healthcare Directive. There are about 1,000 different versions of this form. I just picked the one that's kind of the generic California paperwork. I think the website is Prepare for Your Care. So this is a 15-page document, or 14-page document. The vast majority of it is directions. So as we go through this, we're going to just hit on the most salient directions, the ones that kind of designate what we're talking about in each section. If you're doing this paperwork and making it legal, please read it line by line. Okay, so there are 3 sections in this form. The first section is who is making decisions for you? What are your healthcare choices? And signing it, when does it start? Okay. Your healthcare decision maker can and will be in charge of everything related to your healthcare. Doctors and nurses can't choose to do something for you if it's a healthcare decision that requires consent. They must have someone else speak for you if you're not able to speak for yourself. It gets tricky. Sorry. So here we go. I jumped way far ahead. Here we go. So choosing your medical decision maker. This is talking about who is the person that you want to make decisions for you. They must be an adult. They must be 18 and older. They must be someone who can have a conversation with you about your healthcare wishes, who can be there for you when you need them, that you trust to follow the decisions you have made, and that you trust to know your medical information. You want someone who isn't afraid to talk to doctors and nurses and staff members and not afraid to ask questions. This person cannot be your doctor. They can't be someone who works at the office or the hospital like a random person unless that person is also your family member. If you don't have anybody chosen, then we follow kind of the legal steps of who should make decisions for you, who's your next of kin. This can get tricky when people are estranged from their family, when they are not married to their partner. In some situations, when you have a same-sex partner. If you're in a different state, so in California where same-sex marriages are legal, and you're traveling somewhere else and they say, well, that's not legal, so you're not a spouse. So who's making decisions for this person? They can find themselves completely shut out. If that person is listed on your legal documents, then their opinion on your marriage doesn't matter, which it shouldn't, but that's editorialization. And then if some of the decisions that we are asking to think about, so who has access to your information, decisions about medications and treatments, what happens to your body after you pass? And that's like organ donation and that kind of thing. Then we talk about what are the decisions. Some of these we've already talked about. CPR, and this has written out kind of word for word some descriptions of these medical phrases. So compressions, ventilation, dialysis. Dialysis is something we use to support the kidneys. So it acts as your external kidneys when your own kidneys are not functioning. This typically requires a 4 to 6 hour visit to the dialysis center 3 days a week. It is an extensive, time-consuming process, but it keeps you alive, and typically dialysis is effective for about 10 or so years. We talked about feeding tubes. One of the big questions is things like, do you want to get a transfusion of blood or platelets if you need it? Do you want to be receiving IV fluids and IV medications? Would you want to have surgery in certain situations? And are there medicines that you would say yes or no to? Some people say, well, I'd want everything until they made a recommendation against it. You can write that in. Some people say, I would want this and not that. I want this and not that. Write it all down, absolutely. Be opinionated and document it. Things that your decision maker can help with at the end of life. Calling in your religious or spiritual leader. Deciding whether you are at home or in the hospital. Where do you want to be? Decisions about autopsy or organ donation. Sometimes autopsy is not voluntary, but other times it is. And then decisions about burial, cremation, and services. When you sign this form, and your medical decision maker signs this form, you agree that they can start, stop, or refuse life-saving medical treatment for you. They can decide what happens to your body, and they can decide if your organs are buried or cremated with you or donated to another person. You can elect on this form, there we go. You can elect on this form that you want this to start only when you are no longer able to make medical decisions, or you can say, I want this to start now. There are a few situations where you might say now, if you've had a diagnosis where you know that you're going to have trouble with confusion or clear thinking. That can be things like dementia, a brain tumor, other chronic illnesses where you have chronic oxygen deprivation, like COPD, which is a chronic lung illness. So there are a number of reasons why you might say now. If this is someone you trust, which it should be, and someone who loves you, which it should be, they will continue to talk with you and involve you in your medical decision making, but they would be the one legally who is making those decisions. So then you write down the names of your medical decision maker. I believe we have on this form we have 2. Some forms are a little bit different. And then there are a lot of options on here for you to write in. So you can say why you want a specific person to help you. And that might help your decision maker say, oh, they really liked this aspect of how I make decisions. Okay, that's how I can continue to respect their wishes. There's also a section on here about how strictly we want the person to continue following your decisions that you've written down. There's an option for total flexibility. They can change any of the decisions if the doctors think it is best for me at that time. Some flexibility, or no flexibility, literal. I only want what I have written down and discussed with them. I do not want them to editorialize. Then we move on to making your healthcare decisions. So this is saying, what do we want and who do we want making decisions? So you can put on here, I'd like to make all my own decisions. I would like to talk with other people first, then come back to my doctor and make decisions. Or you can say, I actually don't want you to tell me if I have a terminal illness, and I want you to talk to my son. Sometimes culturally, people do not want to know when they have a terminal illness, and they will decline. There are a lot of different reasons for that. Sometimes it is a culture of shared decision-making, where the head of the family has primary input. And in other cultures, it's because people don't want to hear bad news because that becomes bad news. So there's just different ways of looking at things. What matters most in your life? Being able to be around your friends and family, your pets, doing your hobbies, being able to continue your work, caring for yourself and being independent, not being a burden on your family, which is something I hear from people every day. I do not want to be a burden. Being able to continue and have your religion and spirituality respected, or something else. And there are a number of areas where it's going to ask open-ended questions about what brings you joy and what brings you enjoyment in life. What are your main goals in life? Being kept alive no matter what, or being kept alive while life is good. Just the ad-lib story, had an experience as a nurse where the family for a patient was extremely resistant to making this patient do not resuscitate, do not intubate. It involved week-long conversations with the doctors. And typically at that point there's ethics involved because it was not something that she could be saved from. And in a conversation with their family member in the middle of the night while I was their night shift nurse, it came out that at several times in her life, the patient had said, "Keep me alive no matter what. Do not let them kill me. Do not kill me." And that was what they were doing. And they were respecting her wishes, and they were extremely torn about the situation and what that person was going through. So there can be a lot of different viewpoints about what to do with your medical care and end of life. Okay, there's some sections, I didn't put these in the slides, but how do you rate your health today? How would you feel if your health changed? There's kind of this Likert scale of 1 through 5. So ways that you can kind of indicate and write in what your goals are as your health changes. Then we talk about quality of life. What matters to you at the end of life? If you were in a coma, if you had to be connected to machines to stay alive, if you could no longer think for yourself, couldn't read, couldn't understand a television show, didn't recognize your family anymore, like in dementia, couldn't physically care for yourself, couldn't live on your own anymore, but had to live in a nursing home. What if you had constant pain? So it asks a series of questions about which of these things are worrisome for you? What are the most important things to avoid in your end of life? It asks a little bit about your experiences with people's end of life, and if you were told that you were going to die soon, what would you most agree with? So asking your opinion, which of these resonates with you? I ended up ahead of myself, I think. Yeah. Okay, so at the end of life, some people want to live no matter what, a lot of discomfort, etc. Other people want to make sure that their quality of life is respected and the most important and prioritized aspect. So there are a series of statements that you can say which one resonates with you, which one do you agree with for your care. Then it has questions about organ donation. Would you want some or any of your organs donated as a life-saving treatment for others, or do you want them to stay with you? And that is a personal choice, and people make that decision based on what they need for their end of life and their body. You can elect to have an autopsy, or you can say, no, I do not want an autopsy, we know what's going on. In certain unexpected illnesses, an autopsy is required legally. But if someone has had a chronic illness, it's typically not. And then there are optional places to write in about funeral or burial wishes. and then sections about how do you want to get medical information. Should they talk to you or your decision maker? Should other people, other agencies be involved in your care? Should we be involving your spiritual leader? Some of those other questions. Are there friends that have been very, very important to you that should be involved? The nice thing about this form is you can do as much or as little of this form that you want. So if all you do is write down the name of the person that you want to make decisions for you and sign it, that counts. You can also write a book. You can write a whole novel on this thing about what you want and what you need. And please write clearly, because they are going to have to read through it. There is a final section here where we're doing our signing. So you have to sign, date, all of that. We have to have witnesses. They cannot be medical providers. They cannot be involved in your care, and they cannot, if you're in a nursing home, work where you live. So they have to be people that are detached from your medical care. One of the witnesses must not be related to you and must not benefit from your will or trust. So they can't have any financial connection to you. And then in the final section, which I did not make a slide of, there is the option and ability to notarize. I always recommend that people do get these notarized because that makes it a legal document. If you're in a nursing home, it must be notarized. For everyone else, if your family is in accord and your wishes are clear and have been discussed, it's not, it is still a valuable exercise and document, but it would not be a legal document. So, for example, if you had done this at one point, but prior to that, you had done a will or a trust that had different information in it, legally, that will or trust is what must be followed. So if you have legal document, whatever is legal is the one that has been notarized or legally recognized at that date. So paperwork that is not notarized later doesn't supersede that. And I've done a lot of talking, and I want to leave some good time for questions. Some of this can be really personal. So if you had a question that you wanted to ask me privately, separately, you'd be welcome to do that. You can text me or email me if it's preferable to do it, through a message as opposed to face-to-face. Connie, let's see. We should have, it's up here, Brian. It's on.
And talk about this being really appropriate for Mother's Day, because I think one of the biggest things that parents can do for their children is to bring this kind of clarity. So I think it's a great sync with Mother's Day. I have two quick questions. The stats that you gave for resuscitation CPR on the street and in the hospital seemed really depressing. Does that factor in at all pre-existing health or age or any of that, or is that just like we should think in those terms?
So talking about outside of the hospital cardiac arrest, the stat I gave was 10% success to make it to hospital. That is generalized. So that is across the population of people who have a cardiac arrest. But when we think about that number, we know that people who have terminal and chronic illnesses are going to skew towards less successful. People who are largely healthy, this is people from like 5 to, let's say, 77, who are largely healthy and do not have significant chronic conditions, they're going to fall into that more success. So it absolutely makes a difference. The other thing is timeliness. So if you're in a situation where we're here at church and I see someone fall down and I run over, I start CPR while I'm yelling for 911, Good compressions and oxygenation increases your success rates threefold. So if we are right on it, we end up in more of a 30% situation. But when they present those numbers, they have to generalize them across the lifespan. Yeah.
Then my second question is, how do we factor in the financial implications? Because these decisions, I don't want to leave people stuck with a huge bill, but we're talking about it as if it's sort of equal. So how do we address that?
Finances are tricky and cruel at times. What I like to tell people is that your children cannot inherit your debts. So your medical decision making, the hospital can call them, but they are not in any way obligated to pay and should not. Your spouse, however, can inherit your debts. Because you are a financial couple, you take on each other's medical debt as a couple, which is difficult. In California, we have Medi-Cal, which is the financial-based insurance. Most people who own their own home do not qualify because you have to have, not anymore, not so much. Ooh, I like to hear that. Oh, yay. That's good news. So it can be fairly strict, and it has been in the past. Sounds like things are a little more hopeful, which I love. Oh, sweet. Okay. I might chat you up about that later. So Medi-Cal covers skilled nursing facilities, so your nursing care if you can't take care of yourself physically. It covers your memory care if you're physically up and moving but mentally not able to take care of yourself. Medi-Cal covers all hospitalization, all of your outside of the hospital care, and covers all of your hospice. Medicare, which is age-based, 65 and older, covers hospitalizations, it covers your doctor's office, and it covers hospice. It does not cover skilled nursing. So some of the kind of financial considerations, I'm hesitant to say, consider the finances when you're making decisions about what you want for your health care. But we know that if you are in a skilled nursing facility that requires 24/7 care on a ventilator, that is going to be expensive care. So that we hear stories about people who divorce because of medical debt and that kind of thing, which is a reality that some people have to live with. But as they are aware of it, physicians and medical providers will be honest with you about the effectiveness and costs relative in your specific situation. So in terms of making these decisions, I say base them on your health care, not on financial concerns. Yeah.
I want to give everybody else a chance to ask their questions. If any time remains, I'd like to make 2 comments at the end.
Thanks, Lucy. You're awesome. Can you be around when I'm old, but when I get really old, okay, thank you, Lucy.
I'll try.
Anyway, at what age, is there an age when any of your organs will be not accepted?
That's a good question. To my knowledge, I'm not aware of an age-specific cutoff. There may be people who are in ICU health or that might know a little bit better than me, but it is largely functional. Yeah. And not every donation is a solid organ. So sometimes we are able to donate eyes or skin or other parts of the body that we don't think of as an organ. So there can definitely still be some benefit to organ donation even as you age. Mm-hmm. Mm-hmm.
Thanks again, Lucy. I guess probably many of us are conflicted about the do not resuscitate. And I wonder if you know what choices health professionals make generally with respect to this. Nurses and doctors, they know what it's like, they know what it's about. what do they do? Do they say DNR because they know it's just so terrible, or do they say, no, well, I think it's worth it?
It definitely depends person to person. I personally have had DNR since I was in my 20s. If I live by myself, if I am found down, there is not going to be any benefit to resuscitating me. Please leave me in peace. For people who live in a busy household and might be recognized with immediacy, there's probably a lot more benefit to CPR for you. Yeah. A lot of it is going to be related to your overall health. So for people who are in generally pretty excellent health, there's no like age where we say, oh, here's when you should no longer get resuscitated. But the older we get, the more chronic diseases we have, the harder time we have recovering, and the more likelihood we'll have of needing to go to skilled nursing or kind of have a really prolonged hospital stay. And for some people, you might say, if I was in a rehab center for 6 months but could go home after that, it's absolutely worth it. Good. That's great. Write that down. That information will help inform the medical team about things that you want. So the pink one is kind of all or nothing. Yes or no. Are we doing this or are we not doing this? This form lets you write down the feelings about the situation. So if I knew that all I had to do was make it through 6 months of no privacy and pain to get home again and be independent, that's worth it to me. I'd like to go home again. Okay, but that's information that doesn't necessarily drive that split-second decision of yes resuscitation or no resuscitation, but it helps us determine how aggressive to be with continued care and support after a cardiac arrest. Does that make sense? Okay.
Thank you, Lucy. I wonder if you know of protocols that people keep to make sure, this paperwork is keeping pace with their aging and with their situations and that sort of thing.
There isn't necessarily like a recommended timeline to replace a review. I would say if you have had a major health event in the year, you should look at your paperwork. Does it still match what you want? If you have gotten a big diagnosis, you should look at your paperwork and make sure it still matches what you want. And at minimum, probably every couple of years, you should be looking at that. So life is going along great, fine, and this is, now we're in our 60s and we did our paperwork in our 30s. Ooh, yeah, we need to update that. We just need to make sure that it still matches. Your selections might be exactly the same, and if so, I love that. But we should be reviewing it.
I think I filled out a couple of these already. And 2 questions. Who all needs one of these? Secondly, what happened if you're walking on the street, you don't have this in your back pocket?
To the first question, who needs it? I say, if you think an ambulance might be called for you, you should have one. If your decision is not full code, if you want anything except do everything, you need this form. On your refrigerator. And when you take this, they take it with you to the hospital, you get your original back. Do not let them lose it. They will try and lose it. They will desperately try and lose this. They'll say, what pink paper? I never saw her. Make your own copies and give that to them. You keep this one. You can always redo it, but it's annoying. If you are out and about, you're shopping, and you go down, you're full code. Unless your spouse or decision maker is there with you, people who are responding to that are going to say, I don't know what they want. We have to assume they want everything until he wakes up and tells me to stop. Yeah.
Unless it's going to be a separate time on its own, could you talk about physician-assisted suicide?
That is a big topic. I probably don't have enough time to go very much in depth. Physician-assisted suicide is legal in California. You must be of sound mind. You must have a terminal diagnosis. And I believe that you have to have a psychiatric evaluation showing that you are not suicidal because of depression. So there are some safeguards in place with that. The tragic thing is often people wait until they are no longer of sound mind with things like dementia or maybe like a brain tumor that might affect those things, and then they're no longer eligible. Because you have to be, the person who has chosen to do this has to be the one to administer their own medication and state clearly why they are doing it. So it is very restricted. Yeah. But I'd be happy to answer any more questions about that another time. You have to be terminal here. In other countries, it's different. You can choose assisted suicide for any reason in certain countries, but in the United States and in California, it must be a terminal condition. With no other questions, maybe we can hand it over to Jeff. Thank you.
I think most of you know that I specialize in estate planning and have been doing that for more than 52 years. I can only speak for myself as an estate planning lawyer, but I can tell you that almost all of the others who do what I do, when we do an estate plan, we include a healthcare directive as part of the plan. Well, I started out using the California Medical Association form. Lots of boxes to check. In fact, it was more than half the meeting just going through that. And I finally noticed that people were checking all the same boxes. So I went to another way of dealing with this. And I have my own form of healthcare directive, which I think is pretty good. I'm always working on it to improve it. And I encourage people to sign that, and then I notarize it. Now, the reason I do that, I think this form is wonderful. It's a lot more detailed than the form I have. But when we got bogged down and I sent people home to finish it, I know what happened. 90% of them put it away and they never looked at it again. And I came to the conclusion it was more important to have one and have it signed that can be used than just to let them try to wade through that.
I 100% agree.
Yeah, so when they leave my office, they have a signed healthcare directive, and I give them written instructions to place a copy of that with their primary care physician, so when the emergency happens, the phone call goes out, everyone in the family rushes to the hospital, and the attending physician says, does one of you have a healthcare directive? And the answer is no. Then they're sent wherever to go find one. I had a client, she lived in Fireball with her mom. Mom falls down, breaks her hip, ambulance comes out. Where do we take her? St. Agnes, that's an hour's drive. They get there, they ask for the healthcare directive, and of course it's back home in Fireball, and they sent her home to get it. So I encourage people, in fact, I have 8 doctors and they all have a copy of it. And I think that's a good idea to spread it around, because if the family knows the doctor has it, they know, well, I forgot it, but call Dr. So-and-so and you can get a copy there. That's point one I want to make. The other point I want to make is I read an article by a lawyer who specializes in healthcare issues probably 35 years ago. And this doctor, this lawyer, suggested that there should always be language in the healthcare directive that is for the agent who is making a critical decision, pull the plug. And so that's not really part of this form, but it's part of everything that I write. And I just included it because I thought it was a good idea, and then one day it happened. And those of you who I've written estate plans for have already heard this, but my client was in Clovis Community Hospital on life support, and the physician attending asked the daughter, who was the healthcare agent, what are our instructions? And she completely went to pieces, couldn't deal with it. In fact, she was shown to a little room in the hospital where she spent hours crying, couldn't deal with it, but she had a copy of the healthcare directive in her lap and started reading it and came to that 2-paragraph section that I specifically included. And it had the obvious statements. If there's no quality of life left for me, do the right thing. She told me this story 2 weeks later. She read that and she said, this is my mother telling me what to do. And so she went out, told the physician intending, pulled the plug. And she came to tell me that story 2 weeks later because she said that gave me the emotional strength I needed to do what my mother wanted. So I always include that language because I think it's important. That's all I want.
Well, thank you very much to Lucy for her presentation today. Next week, Jeff will be taking the lead. Join us next week to hear from Jeff about trusts and wills. Have a good afternoon. Say again? Oh, and if you are on Zoom and did not get a copy of these forms
We'll leave 'em
because
here.
we can't send them through the air, let us know and we're happy to provide electronic
mail 'em.
copies. We can
Yeah.
mail them to you. Yep.
And if you want to take an extra copy for someone who couldn't be here today, please feel free. If anyone looked at this form and said, my God, I want this done, I'm happy to do it with you.